Welcome to our weekly webinar. As always, if I could remind everybody who is not speaking to mute their microphone and turn off their video. Indeed, if anybody would just keep their videos off, and then just for those speaking, just turn it on yourselves then when you're coming in, and we'll introduce everybody in turn. So that's just a bit of housekeeping there, as always. So tonight's topic is very much a very important one, and it's focusing on the impact of training during the last couple of months and the COVID pandemic, and how we should deal with training. And we're getting a lot of good perspectives tonight from trainers, trainees, and the college. And so that's really good. But before we kick off, I just have a few things I want to bring to everyone's attention. This week on Friday, we're going to have our virtual induction for our new trainees, our new core trainees starting in ST1, and our specialty trainees moving into ST3 in surgery and in emergency medicine. And it's just to acknowledge all the work that the team in surgical affairs have been doing, but in particular our trainers and trainees in preparing this induction. It's the start of a very interesting, either the start of your surgical training career or the start of the next phase of your surgical training career, and it's really important. And what a year to be starting. It may feel like there's a lot like uncertainty out there, but nonetheless, it's still an exciting time. It's an important time in Irish healthcare, and it'll be great to see the new people joining the ranks. And we wish them all the very best with that. But fair play in getting a virtual induction off the line. It's not how we usually do it, but we have to adapt nowadays, and I think that's gone very well. Also this week, I know a number of sessions have been held, CAPAs and ARCPs and so on with everybody, and that's again, the feedback so far has been very positive. So again, thanks to all our trainers and all our trainees for being so cooperative, adapting so well, and making it as positive an experience for everybody as possible. We also last week set out our mentorship program in general surgery, plastics, urology, vascular surgery. And this is to look at already the program that's already been in place for many years now with trauma and orthopedics. So we thank everybody for getting involved in that mentorship program. I think at this time as well, it's probably more needed than any time to support our trainees and each other in that area. So thank you for everybody getting involved in that. And if anybody wants any more information on the mentorship program, just get in touch with Surgical Affairs, or indeed just consult the website on Surgery. There'll be information there for everybody as well. And indeed, we got our first newsletter out to our faculty of surgical trainers, which I think is, I suppose, a start of, again, a more focused emphasis we have on supporting our trainers and what they need to help get through the challenges of training nowadays and so on. So that's been very important. And then just next week we'll be, well, fingers crossed, one of the busiest men in Ireland, Colin Henry, who's the Chief Clinical Officer of the HSE, will be joining us and talking about the solutions for scheduled surgery and how we get the programs back. So that's next week, and our leads in the clinical programs in surgery and trauma and orthopedics will be joining Colin and our president in that discussion. So that should be very good. So without any further delay, I'm going to invite our president to open up this session and introduce our speakers. And as always, use the chat function to send in any questions or comments you have during the session. All of the presentations we made available to everybody at the end of the session. And I look forward to a lively Q&A session at the end, and also listening to the interesting perspectives that our panel will bring to this topic tonight. So, President, over to you.
Thank you, Kieran, and welcome all. I'm not sure, I think this is our 14th webinar. It really has been a very successful development that we have managed to create a network across the country on Wednesday evenings, and have kept, we hope, have kept people informed and up to date with what's going on in COVID. And indeed, we may very well look in the autumn, when hopefully COVID will be less dominant in our thinking, to having a series of CME type webinars in the autumn. And indeed, most of the specialties have started doing online teaching and mentoring. And I think we should be looking at the glass as being half full here, that yes, we have lost opportunities in the hospitals, but we have gained a whole new blended learning. And I think this is something that will stay with us and probably will at the end lead to a much better engagement. Certainly there is closer engagement and awareness of the needs of trainees now than there was 6 or 12 months ago. You can be assured that the problems being experienced in the College of Surgeons here are no different from those that our sister colleges in the UK are experiencing. And indeed, the presidents are having a webinar on Monday with the chief executives and senior administration across the 4 colleges to try and see how we're going to address this, and particularly address the tricky issue of the clinical aspects of the examinations that we know these are causing people anxiety. We know that they are potentially delaying people finishing their training or even progressing in their training, and every effort will be made to avoid impact. So we're very pleased this evening to have 4 speakers with different perspectives. We start with David Healy, who is the incoming chair of the Irish Surgical Postgraduate Training Committee. We continue with Rustan Mancheka, who is a consultant urologist, but also the program director in urology. And I have to say, from my time on chairing ISPTC, the work that the program directors put in to your training is immense and greatly appreciated. Highly important is to hear from Christina Buckley, who is the outgoing chair of the Irish Surgical Trainees group. And of course, the trainees' perspective is all important, and we must listen very closely to what Christina has to tell us. And finally, to wrap up, Oscar Traynor, who is well known to us all as our Professor of Postgraduate Training in RCSI. So David, I'd be grateful if you take the floor and lead off.
Well, thank you very much for that introduction. And I think Park's going to launch the slides. Great. So again, thanks for the college for the opportunity to talk about this really important challenge. I mean, COVID has been bad enough to deal with without all the collateral damage, and surgical training has certainly been one of the casualties on the collateral side. This whole process has been very disruptive for surgical training, and we need to look at ways to see if we can dampen that disturbance, but still explore the opportunities that do come at a time of disruption and look for the famous fabled creative disruption if we can. The webinar title is Sustaining Surgical Training Programs During the Pandemic, but obviously we're going to address the post-pandemic period hopefully as well. The next slide there. So I won't go into COVID. Everyone has COVID information fatigue, but I will frame the problem in regard to surgical training, and obviously the other speakers will develop it further. The impact, of course, of this has been felt across clinical sites. It's been felt in RCSR activities. The curriculum has been impacted, and the real world, if you will, the realms outside the hospitals and the college have been impacted by COVID, and that's had impacts on our trainees and on their training. Next slide there, thanks. So when the state's health services were looking at all the news from Italy and anticipating the Irish wave, there's no chance to build new hospitals, so all they could do was repurpose the existing infrastructure. So all the clinical sites that you work in were rejigged and rebadged and realigned to a new purpose. Certainly our experience was we lost our wards. They all became COVID wards, and they remained that way even if the beds were empty. Theatres were closed to reduce non-COVID admissions, to free anaesthetic staff to help ICU, to offer auxiliary ICU space. Again, my own experience in one hospital in Vincent's used the theatres as a non-COVID ICU facility. So the non-COVID patients ended up there, and they kept the main ICU, if you will, for the COVID patients. And my experience in the matter was that our high dependency was in cardiothoracics was allocated as the stage 3 or spillover area for the main ICU and HDU. And we were all being given training in ventilators and ICU management with a plan, obviously, to be supported by our ICU colleagues. But thankfully, it never quite came to that. But it certainly disrupted our ability to deliver a service. Outpatients were cancelled or converted into virtual clinics. There weren't too many post-ops to see. You could debate, was there merit seeing a lot of new patients in surgical clinics given the surgical opportunities to deal with them. Team structures were radically altered as team members were seconded to other areas, and the teams were broken up into pods to damage limit any contact with COVID positive team members. Grand rounds were mostly stopped or went online, and team members were often discouraged from going to MDTs to minimize physical presence. The guidance that was written down for a lot of surgery was that it should take place with the minimal number of people present, and that surgery should be performed by the most senior person to speed up the case and expedite it. Again, trainees losing out. And we certainly had, and I'm sure you had too, a number of trainees who were COVID positive, and we certainly had plenty of people who were off in isolation for their 14 days. Surgery did happen in private hospitals, and it was very useful, but it just didn't match the needs, and so waiting lists have hugely increased. So all these different changes have combined to compromise the traditional surgical training opportunities. Next slide there, thanks. But again, as we said to our trainees, you can just go back one maybe, we may never get a time like this again. So there are learning opportunities for this, and the good trainees certainly spotted them and used them. For the RCSI, the normal delivery of group teaching, wet labs and exams were all challenged, but HST interviews went ahead and were completed. Campus sessions have still happened, and education continues in various new forms like this one today. We are living through extraordinary times, and trainees will have learned a lot about knowledge dissemination, decision-making, resources, the roles of health professions and professionals in those decisions, and the role of the expert in advising in that setting. We've had heavy discussions about ethics of triaging patients for ventilators. We've had discussions, obviously, in detail about healthcare protection and PPE. Well, I think a lot of strong trainees have added a lot of new tools to their toolbox, and there are opportunities to redesign the system in the reconstruction phase. It doesn't have to be put back together in the exact same way. And obviously in discussion, any contributions and that will be more than welcome. If you go to the next slide, thanks. So there's a lot of opinion and noise at the moment, but facts are essential, and these are fantastic data from the core training program that Sean Tierney and Donnchadh Ryan have put together, looking at logbook activity in our year 1 CST trainees. And you can see from March, April, May, the 29 numbers on the left of your screen and 2020 beside it. And there's been a dramatic drop in logbook activity for our trainees, 71% odd. Obviously, March wasn't as bad as the other two because there was at least 2 weeks of normal operating at the beginning. But you can see the fall off in opportunity in operative volume. It confirms what you know, but the data is great to see. And it really implies that the opportunity and the training opportunities for the trainees have been compressed accordingly. The next slide then looks at the year 2 trainees. Again, a similar pattern, perhaps even more dramatic, down to 80% drops, probably reflecting the year 2 specialties. And then on the next slide then, we have some really interesting data when you look at it in terms of the different specialties and how the different specialties were affected. The ENT and MaxVax were probably hit the hardest, with a 90% reduction in logged activity by trainees. Really astonishing. And I mean, this reflects the concern about aerosol generating procedures and the risks from that. Even orthopedics and trauma had a significant reduction. Pediatric surgery had quite a reduction, and I'm not totally understanding that. If there's any information on that, it'd be great. I didn't think they got as much of a hit directly with the COVID-19, but I suspect it may have been staff or contact isolation issues which were probably impacting on that service. And then looking at my own specialty, cardiothoracics, there's a 41% drop in trainee opportunity. We have one of our SPRs put together a paper on this and shows that our activity is only operating at 49% of expected activity, and the acuity of the cases has gone up enormously. And as the acuity has gone up, obviously the training opportunities have come down. On the next slide, we see that a lot of the juniors were reallocated to other roles. I certainly lost my intern, the SHO became an intensivist. But this survey here is from 48 people who replied, and maybe not as many were reallocated as I might have expected. 15 out of 48 were reallocated, or about 31%. And on the next slide and the one after, you can see that they were allocated to different roles. I think someone allocated to an ICU role or an ED, you could argue, is going to get something of value out of that from their surgical training point of view. It's hard to see the same reward for patients allocated or for trainees allocated to COVID medical wards. So that was kind of surprising to see trainees allocated there, but that is what happened to at least some of them. So I think that's got to be one of the priorities, is to repatriate surgical trainees to surgical roles. On the next slide, we just see that, you know, at the RCSI level, it certainly impacted on the regular training opportunities such as boot camps, skills and courses. They were all hugely impacted. But there are plans to rehabilitate that, and as you heard from the President, to do some of this online. So a lot of that will be recoverable. On the next slide then, from the curriculum point of view, personally, I felt the CAPA sessions that I was involved in this year were particularly effective. I was very happy with the Zoom method, and I think there's a lot to be said for it, given that there are candidates and trainers in different parts of the country, and it certainly worked in our specialty. The exams have been postponed, and I think they absolutely need to be re-established. And the plan is to do that. I mean, you know, we've rushed medical students early out of graduating, given them their registration early. We've called back medical graduates from abroad. We've asked retired doctors to consider coming back to work. Even the Taoiseach Cleo Varadkar went back and took up clinical work again. I mean, you know, the need there for qualified, competent doctors is there, and on that logic, it remains a core goal to have optimally trained, qualified and certified surgeons, and getting the exams done as part of that. So I think concerns about risk for the trainee or the examiner could hardly be any higher than a day at work. And I think both need to know how to interact with patients anyway, and understand personal protection in the clinical world. So we should be able to do that in an exam world as well. And if you think certification and progression of surgeons is important, then balance of risks should be in favor of getting the exams done. On the next slide then, just to touch on the outer world, if you will. I mean, none of us are solo operators totally, and there's a balancing act between home and work, which is there for everyone, trainees and otherwise. Personally, I have a 6-year-old and an 8-year-old at this time, and trying to keep all that show on the road has its own challenges. You've got no grandparent support, there's no childcare support, your ability to travel, etc., is all impaired, and this is a very difficult time and undermines the platform, if you will, for trainees and training. So I think to conclude, I'd say that surgical training by the traditional measure has really been a collateral casualty of the COVID pandemic, and it's no one's fault. So no one's going to be punished because their logbook took a dip beyond their control. But you can see that the strong trainees are taking the opportunity to do lots of other useful things, and some will come through this with a lot achieved and in a much stronger position. But it won't be possible to come through this without some disadvantage. And that's why we're having sessions like this today, to see what we can do to minimize that, and where possible, where we can repair that damage. So I'll pause and finish there. And I think Rustam is going to take us through a specialty specific view of this.
Thank you, David, and thank you, Ronan, for the opportunity to speak to everybody this evening. Thanks, Erica. You can put the first slide up. So I shall describe the impact of the first wave on urology services, looking at it through the prism of my primary hospital, which is Tala, and then attempt to describe what I think things would look like beyond the first wave, again from a urology perspective, but I think there will be some relevance to a lot of other surgical specialties. Obviously, during the first wave, and certainly by mid-March, in most hospitals across the country, elective surgery had essentially ceased, and certainly ceased for the first 2 or 3 weeks. And as David described, this was for a myriad of reasons. To convert operating theaters into ICU facilities and to free up staff, etc. Emergencies continued to function as normal, and outpatient clinics were largely conducted by phone. Diagnostic procedures were largely suspended, although we had to maintain a highly selective, high-risk diagnostic service. So things like prostate biopsies were stopped for a significant part of the first wave period, and flexible cystoscopies were performed only for high-risk patients, so patients who presented with visible hematuria, who had other high-risk features, and patients who had high-risk bladder cancer who were on surveillance. But things like urodynamics, etc., uroflows and LUTS assessments, they were all completely ceased. Our urodynamics nurse was redeployed for contact tracing, along with a lot of other outpatient staff. Erica, next slide, thank you. From the 1st of April, we had access to private hospitals for some elective surgery. And again, initially, we confined this to what we described as time-sensitive conditions. So these were largely in the context of urology, high-risk oncology surgeries, and some imperative stone surgery. And again, these were highly selective because with aerosol-generating procedures, we didn't want to expose theater staff, anesthetic staff, etc., and surgical staff to the additional risks performing surgeries that could safely be deferred for a period of time. Access to private hospitals varied across the country, and as we discussed at our training council meeting, some parts of the country didn't have as much access to private hospitals for continuation of elective surgery, and this obviously had an impact on training opportunities. Again, initially it was largely consultant provided in order to minimize cross-contamination. But gradually, as the period wore through, we started to bring some trainees across to our scheduled lists. Emergency surgery is largely continued in our primary hospitals, and these were things like suspected torsions, obstructing stones, hematuria in patients who are in clot retention, genitourinary trauma, Fournier's gangrene, priapism, that sort of thing. Next slide, please. So we put together some data from our Tala center, and we identified from the 1st of April to the 31st of May, an 8-week period, and we compared the comparable 8-week period 12 months prior to look at the fall off in activity. So emergency admissions were largely comparable, a very slight decrease in emergency presentations. But what we noticed with the emergency presentations were a significant number of presentations were delayed, resulting in sicker patients, patients with obstructing stones, who had colic, endured pain for several days at home before presenting. And often by the time they had presented, were showing signs of sepsis. We had several patients requiring critical care support because of severe sepsis. There were a couple of presentations of delayed torsion, which led to testicle loss. And there were some delayed soft tissue infections like Fournier's, which led to considerable debridements. The bullet points here really are around the fall off in elective surgical activity. And you can see really we're doing about 10% of our elective surgical activity in spite of having access to private hospitals. Diagnostic procedures running at about 50%, but certain diagnostic procedures like prostate biopsies, we were only doing about a quarter of the volume we were doing in a comparable period last year. Shockwave lithotripsy, because we're one of the national stone centers with a static lithotripter, we continued to do some shockwave lithotripsy, but not for elective stones. So the non-obstructive renal stones were deferred, but we started doing a lot more hot lithotripsy. So patients presenting with acute ureteric colic with stones within the ureter, instead of bringing them to the operating theater for ureteroscopies, some of those patients were having hot lithotripsy with a reasonable amount of success. Urodynamics was obviously completely ceased. And the other relevant thing to highlight is the new cancer diagnoses. About a third, a fall off by 2/3 in the new cancer diagnoses. And only prostate cancer diagnosis was just about 15% compared to the same period last year. Next slide, please. We looked at the mean number of operations that 2 SBRs in Tyler performed in a month. And in the era prior to COVID, they were performing approximately 50 operations per month. This did not include diagnostic procedures like truss biopsies and flexible cystoscopies. These were largely surgeries in the operating theater. And during the first wave, this had reduced to 7, and they were mainly emergency ureteroscopies. And it's important that the period where the average number of operations per month was 50 was actually the winter months of January and February. So in spite of the traditional winter fall off in elective surgical operating, we still had a reasonable amount of surgical activity, and you can see the impact that the first wave had. Next slide, please. Obviously, other training opportunities beyond the operating theater were hampered. In-house teaching, which included ward rounds, which were business ward rounds. Some of them were conducted in a dry round or a board capacity with limited team members. MDMs and X-ray conferences, as David alluded to, were really reduced to the bare bones. We had one registrar who was on call for the weekend, who had the opportunity to prepare for the X-ray conference, present all of the cases in conjunction with 2 consultant urologists who would attend. We did, after the first number of weeks, establish some video conferencing facilities so that others could dial in. Urodynamic meetings, journal clubs, micro-topic teachings, research meetings, etc., were all suspended during the first wave. At a national level, we had 3 training and study days that were cancelled, and projecting into the future, we made a council decision to cancel our ISU annual scientific meeting scheduled for September of this year, which again presents a lost opportunity for teaching and for presenting research. At international level and at national level, lost opportunities to attend courses and conferences. Next slide, please. Then, in terms of ST3s and exams, then so the ST3 interviews we managed to sneak in about 4 days before national lockdown through absolutely Trojan effort on the part of the college and a whole pile of trainers that came together late on a Friday evening to run interviews late into the night. So we managed to conduct our ST3 interviews on a face-to-face basis, which is in contrast to the UK, which suspended all face-to-face ST3 interviews, and candidates were ranked purely on self-assessment scores without the need to actually submit evidence, which disadvantaged some applicants who may have made up some ground at interview level. So fair play to all concerned. With regards sort of the FRCS UROL exit exams, 2 were scheduled to sit the exam in May, and they have deferred the exam to November. The JCHSD have released a revised exam schedule, and the Part 2 exams that were scheduled for May for most surgical specialties have been rescheduled for the end of 2020. Now, it remains to be seen, with the limited number of spaces and the increased demand for exam spaces, whether they're going to have the capacity to do that. And the same applies for those wanting to do the Part 1, which was initially scheduled for July of 2020 and has been deferred to January of 2021. And again, there'll be additional trainees who will be eligible to sit the Part 1 in January, who will also be looking for places, but the JCHSD will guide us as to how that's going to work. Next slide, please, Eric. In terms of the impact of COVID on fellowship, we had one urology trainee currently in ST8 who was on fellowship in London, doing a uro-oncology fellowship. Because it was a uro-oncology fellowship, her surgical logbook was affected only for a short number of weeks, and she had actually exceeded her own expectations in terms of indicative numbers for her training prior to that. So, and she had more than exceeded the minimum requirement for CCT. So she actually passed her RETA in June, but will be continuing for 2 additional months in London, and then continuing on in the same department as a junior consultant. None of our trainees were scheduled to head abroad, either for out-of-program training or for post-CCT fellowships this July. So thankfully, COVID hasn't had an impact on fellowships due to commence July 2020. There is some there are some recommendations around fellowships, if they have been cancelled or deferred, that the training committees will try to find training posts within Ireland. And obviously, if those are post-CCT fellowships, then they could be offered temporary locum posts until their fellowships are resumed. Next slide, please. Next slide, thank you. And so beyond the first wave, I mean, the impact of, can I just go back one slide, thanks. Yeah, thanks. So beyond the first wave, the impact of surgical activity is likely to have a continuing and long-lasting effect. And again, some hospitals will be disproportionately affected. Some hospitals and hospital groups have access to spoke-style hospitals like St. Joseph's and Raheny and Loughlinstown, St. Michael's, etc., where some elective surgery will resume at a faster pace, I suspect. But this is not universal across all training sites. In addition, surgical volume is not going to be the same. We're never going to do the same number of cases per list due to the restrictions to maintain bed occupancy at about 80%, and also physical distancing requirements, etc. And the impact of rolling closures and NTPF, the group in Cork actually examined this and showed that there was a reduction in core urology procedures, a significant reduction in core urology procedures through the NTPF back in 2013. So we really need to try and flag that. And where opportunities arise to resume some level of elective surgery, in private hospitals through various mechanisms like the NTPF, I think we need to examine the possibility of bringing our trainees out to maximize those opportunities. The winter crisis, I mean, it hasn't been a winter crisis for a while. It's really become a year-round phenomenon in many sites for the last number of years. And that's going to compound training opportunities. Next slide, please. With respect to in-house teaching, we expect this to resume. Fortunately, urology is a small specialty, so we should manage physical distancing. Obviously, where that's not possible, the use of virtual platforms, and we're getting pretty slick at Zoom and MS Teams, etc. And at national level, then we anticipate resuming our program after the summertime. The study days would lend themselves quite usefully to the virtual and web-based platforms, but we also have Viva-style teachings, which ideally need to be in person. But we should manage that in a physically distancing style come September. And the final slide then, please. As you said, we suspended our national meeting scheduled for September. Are trying to examine the possibility of perhaps having a brief scientific meeting so that those who submitted abstracts, etc., for presentation will have an opportunity to do that. And finally, then, in terms of training assessments, we will need to examine the impact on indicative numbers and perhaps introduce additional assessment tools like competence-based assessments rather than relying exclusively on indicative numbers. And I'm going to leave it there. Christina, I'm sure, will add a trainee's perspective, and then I look forward to discussion after that. Thank you.
Thank you, Rostrum. That was very informative. And we're going to now move on to Christina Buckley, who is, as I say, the outgoing chair of the Irish Surgical Trainees Group and also a senior registrar in plastic and reconstructive surgery. Christina.
Thanks very much, Prof. O'Connell. And good evening, everybody. I have to say that during this role as trainee representative, I've always found it quite challenging to speak on behalf of every trainee, as obviously we're a hugely diverse group. So what I'm going to try and do is give a broad overview of the current trainee perspective on the impact of COVID and what challenges lie ahead. I'm going to focus mainly on the HST perspective, as David Healy has covered very nicely the challenges that the ST1 and ST2 trainees are facing. So hopefully the issues that I raise will generate some good discussion points, as the other speakers have said. Next slide. So I don't need to tell any of you that COVID-19 has brought about huge changes to our surgical practice. And all I want to do is just frame the environment that the trainees suddenly found themselves in. So essentially, we had an initial complete halt in operative activity, along with an instantaneous change to almost 100% virtual outpatient delivery. And on top of that, then we also did move to quite an intense online delivery of teaching and webinars, which was actually really great. Next slide. This is just a snapshot, essentially, of the COVID impact on surgical caseload for ST3 to ST8s across all specialties. This data was recorded over a forward period from April, the beginning of April to the beginning of May. And it was collected by Amy Fowler, one of the vascular trainees in Galway, which she very kindly shared with me. So essentially what this is showing is that although there was a reduction, SBRs were still performing quite a decent volume of emergency cases per week, as Mr. Mineshka alluded to. And the bar chart on the right simply shows the pre and post-COVID emergency cases that were performed relatively independently by SBRs with consultant and supervision. Next slide. And then just a contrast, essentially, there was a dramatic drop-off in essential elective caseload as expected. And then again, the bar chart on the right is showing the pre and post-COVID elective cases performed by trainees. Next slide. So this is mirrored across other European institutions. Similar findings have been published in terms of reduction in operative exposure. However, there has been an increased opportunity essentially for remote academic learning and research reported in groups initially in the Netherlands, which I think a lot of countries will agree with. Next slide. And this is actually just a really nice correspondence that was published only a few days ago by the Belgian group in the BJS, and it just is very simply showing that there has been a significant increase in academic activity amongst trainees, with 81% of trainees finding time to widen their knowledge base, and 65% of higher surgical trainees reporting an increased research output. So next slide, yeah. So overall, from a trainee perspective regarding the impact of the last few months, it's definitely not all bad. We essentially experienced an 8-week halt of surgical activity bar emergency work. However, the overall impression amongst trainees and consultants alike was that patient presentation to ED, significantly dropped off during this time. Following this, then we had a resumption of services in the private institutions and in Model 3 or 4 hospitals, and this was entirely dependent, as previously said, on geographical location. I think the experience in the Dublin hospitals varied in comparison with other hospitals across the country, and this was primarily dictated by the varying COVID numbers as well as the type of hospital available in the various counties. So I think the reality is that our surgical training programs can probably absorb this reduction in operative caseload, as it was quite short-lived. And the majority of hospitals, from what I can tell, could outsource their surgery. So really, I think the real challenge is what lies ahead from a trainee point of view. And the most pressing concern is how we're going to deliver surgical training over the next 12 to 18 months. Next slide. So, I mean, I know we're not post-COVID, but we're kind of at a juncture, definitely of what path we should go down in terms of how to deliver surgical training in this new environment. Next slide. Looking ahead then at the recovery phase, as it's been called, and this obviously will need to take into account that there could be second or multiple waves. We're faced with what we think will be the new normal, and that's going to go on for the next 12, 18 months, even perhaps longer. So I really think that surgical training and exposure is going to be dependent on 3 main things, as have previously been mentioned. The main thing is obviously our overall surgical volume, and what we can realistically do on a standard surgical list is going to be dramatically different than what we used to do. And this is also dependent on bed capacity, which is also going to be different now post-COVID. And then these both interplay with the varying COVID protocols across institutions. And I think there's going to be a variety of needs really across the different SPR experience grades, more so than ever, and also across the subspecialties. I feel the hardest hit will definitely be the more junior SPRs, and as well as probably the more elective specialties, especially from my point of view in plastic surgery. Time-sensitive oncological cases will definitely prioritise, appropriately so, over more elective specialties. Okay, so the next slide. So I just want to address that kind of 2 main areas. The first one is the operative concerns. So in terms of operative exposure, these are just some of the concerns that I've heard voiced from the trainees over the last few weeks. Now that we begin to resume elective surgery again in the public institutions, it's very clear that lists are going to be reduced, and understandably so. And there may even be some pressure from external sources for consultants to perform the cases, as was the situation during COVID, to speed up the situation. Certainly there's going to be a diminished elective exposure for the trainee, and this will have a knock-on effect on achieving indicative numbers. And then combining all of this on top of the normal pressures that our healthcare system faces, like Mr. Minette says, essentially all year round, but we do call it the winter crisis. So then, next slide. The second area then just want to address is there is a very genuine concern, which is acknowledged, about the FRCS exams. No doubt COVID has had a considerable effect. There have been 30 SPRs in total who were unable to sit their FRCS exams across all the specialties. Now, I do understand there are ongoing efforts being made by the JCIE to accommodate trainees in this regard. And certainly the biggest challenge will be the clinical and viva sitting. But perhaps there is a discussion to be had regarding moving away from a more hospital-based exam. There are already alternatives out there, for example, the UEMS and the American board exams. So this is definitely something I think we could discuss further. Then just in terms of fellowship training, I think there's probably been a perception that a lot of trainees couldn't go abroad. However, I don't actually think that's the case, having talked to the various groups yesterday. There are only 4 SPOs who had to delay the start of their fellowship. All of these trainees are in orthopaedics, and it's hopeful that their fellowships will commence in 3 to 4 months' time. And there was 1 ENT trainee who couldn't go away, however, instead took up a consultant post in Ireland. And the remainder of the trainees across the other specialties in general surgery, plastics, urology, etc., they're all starting their fellowships in July and August 2020 as planned. Next slide. So, I mean, ultimately, the challenges to surgical training are always numerous, and they're ever present. I think COVID is just an extra thing to add to our existing list that we've always had, like theatre closures, the European Working Time Directive. I think we have a very unique opportunity to reconsider the delivery of surgical training. It's really important that we just don't go back to business as usual. I feel we need to embed all of the really amazing transformative approaches that we developed during this pandemic. For example, reconfiguring our elective surgery and offering a digital outpatient service, as well as all of the really good online teaching that's been reported. Next slide. So COVID did force us to completely rethink and reshape the structure and delivery of our entire healthcare. So I don't think training should be any different. This challenge shouldn't be surmountable given what we've accomplished in the last few months. And I think ultimately we needed, which is always the way, this external stressor as an opportunity to drive some really positive change. Next slide. So then just in terms of solutions, Professor Trainer is going to focus on this in his talk, so I'm just going to very briefly touch on this. In my opinion, I think restructuring elective surgery should be our priority. I know it's not a training, but it links in so heavily with training. I think this was required prior to COVID, and our pre-existing problems with bed and theatre capacity are unfortunately only going to get worse. And whatever the solution is to this, I think it's really imperative that we remember that the trainee, needs to follow the patient and that they be involved in that discussion. Simulation is obviously not a new endeavour for CSI by any means. However, I think we can look to maximise it as a learning tool, especially for more junior trainees where operative exposure is going to be maybe more of a challenge than with the senior trainees. And then just last slide. So in summary, I suppose this is my opinion on it. I think we had a little bit of a break, during COVID, but this time seems to have been used quite effectively by trainees to focus on teaching and research. Following then that initial halt, many trainees were given quite an unexpected opportunity actually to increase their operative caseload in the private institutions. I know personally we outsourced over 100 general anaesthetic procedures and over 80 local anaesthetic procedures to our matched private institutions, which was fantastic. I've done a huge amount of operating in the last 4 weeks alone, which has been great. I think the next 12 to 18 months is going to be really challenging for every aspect of healthcare, obviously, and this includes surgical training. And I think we do have a unique opportunity now to reconceive training and hopefully take advantage of the strengths of this new normal that we're about to face. So that's it. Thank you very much for listening.
Thank you very much, Christina. And it's very gratifying to hear that you're ending on a more positive note, because change is needed, and the external stressor will be the force that will really result in these changes that you've mentioned. Oscar is going to take us through the final presentation, and then we look forward to having a robust discussion. Thank you, Oscar.
Thank you, Ronan, and good evening, everybody. So Christina and Rustam and David have given a very good account of the devastating impact and unprecedented impact that COVID-19 has had on surgical training over the past 3 to 4 months. And what I'd like to focus on over the next 10, 15 minutes are ways that we could perhaps mitigate the impact of COVID-19 over the next 12 to 18 months. And I think we are looking at 12 to 18 months of disruption. Next slide, please. So before we come up with some solutions and some recommendations, there are some realities that we need to consider. Firstly, it's very clear that there will be a very significant backlog of both urgent and elective surgical cases. And not only surgical operative cases, but also diagnostics, including endoscopy, and outpatient clinics. There will be an ongoing requirement for PPE and social distancing. There will be very significant capacity issues in all Irish hospitals. We will need to develop new approaches to patient consultation in the outpatient clinics, on the wards, and in the emergency departments. There will be pressures which we need to resist for surgical cases to be performed by consultants or senior trainees. There will definitely be pressures to rethink the working day and to extend the working day in the surgery, and also the working week. And last but not least, there are infrastructural deficits which became very obvious during the COVID-19 crisis in the Irish healthcare, and these have not gone away. Next slide, please. So, next slide, please, Erica. So if we look at these in a little more detail, firstly, the backlog of elective cases. So these are figures from the NTPF, which, as you know, is the entity responsible for managing the national waiting lists. And these figures are for the period of the 5th of March 2020 until the 27th of May 2020. So it's the 13 weeks when COVID was at its worst. And these graphs show the waiting lists for both day case procedures and inpatient procedures. And we can see that the waiting lists for day case procedures have increased by 16,000 in just 13 weeks. So that's more than 1,000 additional cases on the waiting list for day case procedures during the COVID crisis to date. The figures for inpatient procedures don't look so bad. They've increased from just over 20,000 to just over 24,000. So it's a little over 4,000 of an increase. But this is obviously an underestimate because these are patients who are on the waiting list for inpatient surgical procedures. And in order to get on the waiting list, you have to first of all go through outpatients and then go through a diagnostic pathway, which includes diagnostic radiology or endoscopy or other diagnostic procedures. And we know that these diagnostic pathways have been severely disrupted during COVID-19. So the actual number of patients who will be waiting for inpatient procedures is likely to be much, much more than what we're seeing here in these graphs. Next slide, please. As an example of the problem with diagnostic pathways, these are the waiting lists for the same period for GI endoscopy. And we can see that the numbers of patients on waiting lists have increased from just under 23,000 to 35,500 in the same 13-week period. So that's a massive increase in the number of patients waiting for diagnostic GI endoscopy. And figures just released last week from the Irish Cancer Society show us that there are now 2,700 patients waiting for urgent colonoscopy. And of those, 1,300 are waiting more than 28 days, and 900 are waiting more than 90 days. Sorry, 300 are waiting more than 90 days. Now, I suppose over the last few years, we're seeing these figures so often that to some extent we've become a little bit desensitized by them. But these figures are actually truly shocking. To think that there are 1,300 patients currently in Ireland waiting more than 28 days for an urgent colonoscopy. That is truly a shocking figure in my view. Next slide, please. We also have a big problem in waiting lists for outpatients. So from the beginning of the COVID crisis, we had 557,000 people waiting for outpatient clinics. That's more than 500,000 people. And that number has increased by almost 20,000 at the present time. So in a population of just under 5 million, we currently have 575,000 people waiting for an outpatient appointment. This is simply unmanageable. Next slide, please. The second issue that we need to confront is the ongoing requirement for PPE and social distancing. Next slide, please. So as surgeons, when we talk about PPE, we generally tend to think about PPE in the operating theatre. And undoubtedly, there will be an increased requirement to use more sophisticated PPE for many of the surgical cases that we perform. But it extends way beyond the operating theatre. There will be requirements in some situations to wear PPE on the wards when we're seeing patients, in the intensive care unit, and even in the outpatient clinics. And this use of PPE will have significant implications for the efficiency in which we run our operating lists, our ward rounds, and our outpatient clinics. There will also be issues about training our trainees in the correct use of PPE, particularly in relation to donning and doffing. And of course, there will be significant costs for hospitals and the healthcare system for the use of additional, more sophisticated PPE. In a radio interview with RTE Radio last week, the CEO of the HSE, Paul Reid, said that the estimate for annual costs for PPE will be €1 billion per annum. That is €1 billion for equipment that is single use and goes in the bin straight after it's been used. That is, of course, going to have an impact on the other services that we deliver in the HSE and in the health service at the present time. Next slide, please. There will undoubtedly be ongoing capacity issues in all Irish hospitals. We know that we have a major problem with capacity in the Irish healthcare system at the present time, long before COVID-19 happened. Next slide, please. But the current situation that we've had in recent years with overcrowding in our emergency departments, the trolley crisis, overcrowding in the outpatient clinics, that simply will not be able to happen in the future because social distancing requirements will preclude it. And so there will be major challenges in managing the emergency departments, in managing our outpatient clinics. Undoubtedly, our outpatient clinics are going to have to be smaller and less efficient than they are at the present time. Next slide, please. We will need to develop new approaches to patient consultation, both in outpatients and on our ward rounds and in the emergency departments. Next slide, please. Next slide, please. Over the past few weeks, we've seen an upsurge in the use of teleconsultations and video consultations. And these certainly have allowed us to carry on some activities that perhaps would not have been possible otherwise. But there are challenges in the use of these new technologies in consultations, both inpatient and outpatient. Firstly, there are communication issues. It's a very different experience that patients have when they're talking to a doctor online or on the telephone. And our consultants and our trainees will need specific training in the communication issues around using video consultations and teleconsultations. Next slide, please. There will undoubtedly be pressures for surgical cases to be performed by consultants and by senior trainees. And this will be particularly the case in cases that are being performed in the private hospitals. And this is something that we absolutely need to nail from the word go. Trainees will need to have access to cases in the post-COVID era. There will undoubtedly be pressures to rethink the working day and the working week, to extend the working day from 8 AM to 9 PM or even 10 PM. and to work at weekends and do operating lists at the weekends. And that's fine, except that the hospitals don't have the staff. They don't have the staff at the present time, even to do normal working days. Lists are being finished at 4 o'clock or even 3:30. So the idea of extending the working day to 9 o'clock or 10 o'clock is simply one that will require a lot of additional resources in terms of nursing staff, anaesthetic staff, and other allied staff. And it will have implications for surgical trainees, because many of our surgical trainees have children and families, and childcare and schools are going to be a major problem. At the present time, we don't even know if all the schools are going to be fully open in September, or if they'll be on a reduced working week. And these things all have significant implications for our surgical trainees. And finally, the infrastructural deficits in the Irish healthcare system were thrown into sharp contrast during COVID-19. I'm talking about things like a national shortage of ICU beds compared to every other country in Europe. I'm talking about a significantly poor IT infrastructure in the Irish healthcare system. These deficits were sharply seen during the COVID-19, but they have not gone away, and they will be there going forward. Next slide, please. Next slide. So what recommendations can we make going forward to try and mitigate the impact of COVID-19 and the post-COVID-19 era on surgical training? Well, I think the most important principle that we must have is that wherever patients are being seen, opportunities for training should be taken to help trainees make up for training time which has been lost during COVID-19. This will undoubtedly involve trainees rotating outside their academic teaching hospitals to private hospitals, because undoubtedly the private sector will continue to play an important role in the management of the backlog of clinical cases going forward. But rotating surgical trainees to the private hospitals is not quite as simple as it might sound. There are issues that we will need to address before that can happen. Firstly, there are issues around medical council registration. So right now, surgical trainees are on the trainee specialist division of the Register of the Medical Council. And under the terms of their registration, they can only work in the training sites, the accredited training sites to which they've been allocated. So moving to the private sector will pose problems with the Medical Council. I think we can predict that the Medical Council will be sympathetic on this matter. They have already clearly stated that trainees must be allowed every possible opportunity to make up for the losses of COVID-19. So I think there will be sympathies there. And indeed, there is already a precedent set during our core surgical training programme when some of our trainees do rotate to the private sector. So the medical registration issue is probably not going to be a major problem. A much more thorny issue is the issue of indemnity. So at the present time in the public sector, all of our trainees are covered by the state's clinical indemnity scheme. That will not cover patients who are being treated under NTPF in the private sector. And so we will need to organise some way that we can assure the trainees that they are adequately indemnified if they're working in the private sector. We can predict that the private hospitals are unlikely to pay for indemnity for trainees rotating there because it is no advantage to them. But somehow or another, we need to find a way that trainees moving from the public sector to the private sector for specific cases will be adequately indemnified. The next challenge with the private sector is that the private hospitals themselves have accumulated a very large waiting list of elective surgical procedures over the past 3 to 4 months. And they need to get rid of that backlog as well. So they can't open their doors completely to public patients coming in through NTPF. But undoubtedly, they will have to play a significant role in the management of elective surgery backlogs. The next problem in the private sector I've already alluded to, and that's the pressure for consultants to do the cases rather than allocate them to trainees. And the final issue about the private sector is that under the current model, patients on the NTPF scheme who go to the private sector are not necessarily, in fact, are very rarely operated on by the surgeons who saw them in their base hospital. In many cases, patients in the NTPF system are operated in the private sector by full-time private consultants. And these consultants they're not on our current list of trainers. They may not necessarily have the skills required to be a trainer, or they may not even have the desire to be a trainer. And so these are issues that will need to be sorted out as well. So undoubtedly, trainees must be facilitated to follow patients even to the private sector, but there are challenges. They're not insurmountable, but they're challenges which we need to address sooner rather than later. The second recommendation is that we need to expand the role of simulation for both teaching and assessment of both technical and non-technical skills. As most of you know, at number 26 York Street, we have a world-class, world-leading simulation centre, and we need to maximise the integration of simulation into our teaching programmes. However, I think that we also need to develop a network of regional simulation centres around the country, in Cork and Galway, Limerick and Waterford, in our other major academic centres. We need to have lower grade simulation centres than we have in York Street, but simulation centres that will avoid trainees repeatedly having to travel to Dublin. Thirdly, we need to exploit the online teaching modalities to their full potential. Over the past 3 to 4 months, we have been thrown into a situation where we have had to adapt to online teaching modalities. And many of the specialties, general surgery, vascular surgery, and many others, have already developed a suite of online teaching courses and teaching programs for their trainees. But there certainly is a need to develop these further, and particularly to work on the educational pedagogies of these teaching modalities. Fourthly, we need to leverage the educational pedagogies which we in RCSI have developed over the past year in the new Masters in Surgical Science and Practice. I'm talking specifically about simulations for teaching ward rounds, how to conduct a ward round, how to lead a ward round, how to run an outpatients clinic, how to manage a night on call in the emergency department. These are all important competencies in the new intercollegiate surgical curriculum, which will be introduced in August of next year. These are important capabilities in practice, which all trainees will need to be able to demonstrate at the time of sign-off before they get CCST. We also need to formalise teaching in clinical decision-making and clinical judgment through the use of simulated MDTs and case-based discussions. We need to enhance support for surgical trainers, and we've already started that process through the development of the Faculty of Surgical Trainers under the chairmanship of Bridget Egan. But we need to provide supports for trainers, particularly supports in how to effectively deliver online teaching, how to give effective feedback, how to teach technical skills in a constrained environment. We need to ensure the physical safety and the emotional well-being of our trainees by putting formal support structures in place which are easily accessed by trainees at all times. And over the past few months, RCSI Surgical Affairs, in collaboration with some of the other postgraduate training bodies, have been developing a suite of well-being courses and physical safety courses for our trainees. We should integrate the recently launched RCSI online professionalism course into the curriculum for surgical trainees in all specialties. Again, this course addresses the competencies and domains of professional practice which are outlined by the Medical Council. And the Medical Council have recently reiterated a recommendation that training in the Medical Council's 8 domains of good professional practice should be made mandatory for all trainees. This needs to be explicit and embedded into learning agreements and be part of everyday teaching and learning during clinical rotations. There should be greater emphasis and awareness of the 8 domains for both trainers and trainees. So I think we can predict that we're going to see a lot more of this from the Medical Council, and indeed we've already seen it from the GMC in the UK. We also need to increase the number of academic programs for professional development that we deliver to our surgical trainees and allied healthcare professionals. So I reference particularly the Masters in Human Factors and Patient Safety, which is a program which has been run for both consultant surgeons and also surgical trainees over the past 4 years now. And that program will be commencing again in September of this year. And finally, we need to develop a flexible approach to prolongation of training or delay in CCST as a last resort in cases where trainees simply cannot reach their indicative numbers of surgical procedures or reach the required competencies for sign-off for CCST. I think that we need to maintain a rigorous educational experience despite the limitations imposed by COVID-19 and the post-COVID era. Thank you.
Thanks, Oscar, and thanks everybody for the presentations there on that. And a massive amount of information I think everybody presented there, and some really kind of provocative thoughts that we have to think about. Now we've had a number of questions coming in. I came in before the session and that I want to put to the panel, and I think some of the questions that are probably on my mind. We mentioned a few times that we need to think differently about the approach to training and training progression, and we have a kind of a link between length of time, and I think Rustam mentioned as well that the logbooks and just simple numerical numbers like that are maybe not sufficient anymore, and we have to think more around the competency-based training. How do you think at the moment, and this is open to anyone on the panel, that our current curriculum and the detail on that curriculum is sufficient for us to be able to go down the road of competency-based training and not just looking at time and numbers of cases? So whoever wants to go in first on that.
Okay, well, in the absence of a rush to the microphone, perhaps I should come in there and say, yes, I think that the new intercollegiate surgical curriculum program, which is coming out in August of next year, I think that is a really comprehensive curriculum. It's very robust. I think the assessment methods within that curriculum are very good. I think it's a significant improvement on what we've had over the past 10 years with the ISCP.
Yeah. Anybody else want to comment on that in terms of our systems for going down the road of competency-based training? Do we see that as a way of indeed perhaps even shortening training and being more resilient against the likes of COVID-19 impacting on elective procedures? Rustam, what do you think?
I have always been a proponent of competence-based assessments. I think the indicative numbers are important to a certain extent. However, we can see that over time, the indicative numbers for procedures have actually dropped to reflect the drop in access to those cases. So we've ended up having to modify those indicative numbers purely because we're not getting trainees able to perform the number of cases. And you know, you could have done 120 TURPs poorly, and meet the indicative numbers that allow you meet your minimum requirement, or you could do 80 really well and actually be a more competent endourologist than someone who's met the indicative numbers. So I think it is going to be important. I think as Oscar said, the ISCP formula where you've got graded levels of competency each time you enter a procedure-based assessment. And I think the onus is going to fall to the trainers to make sure that you use the grading system as it's truly intended. And I think that's really going to be, so just because you've completed a case doesn't mean you get a 4B. And we've seen at our ARCP, an SD4 performing a TURP, and maybe it was a fantastic TURP, been given a 4B and a PBA, which is essentially independent practicing level. And there's no way an SD4 could have reached 4B on that operation at that level. You know what I mean? So I think it's really, the trainers are going to have to really engage with ISCP and really kind of understand the grading system and apply it so that we can reliably then, when we're assessing competence, use that.
That's great. Thanks. And you can see, so essentially we have very good systems. We now need to start maybe engaging with them a bit differently and look at that. Christina, I know you mentioned just that you said you don't want to talk for all trainees and you're giving a perspective. But in fairness, I think you have a really good handle and good perspective on that. And I know many of your colleagues on the ICG feedback to us very well. But one of the areas that maybe we need to think about is maybe a different approach to how rotations actually work. This idea that you're always in the one base all the time, that perhaps within a hospital group, the HSE has to think quite innovatively about moving certain types of clinical activity to their Model 2s, Model 3s. And therefore, to kind of get the experience and the operative training that you need, you might have to follow the patient workload to those areas. So is there, how have people been thinking about how that might work, or any ideas?
Well, I think that's very dependent on the specialty that you work in. Like, I can only speak for plastic surgery from a HSE point of view, but we do follow the patient to our Model 3, Model 4 hospitals. The majority of the bigger units have a smaller unit associated with them, and they would get more local anaesthetic day case procedures done there, because a lot of our workload is minor cases. But I think, just reflecting on what's worked really well the last few weeks, it's definitely outsourcing patients and being able to offer an elective service without interruptions, without beds not being available, being cancelled last minute, without traumas, emergencies, everything else coming in on top of it. It's been a really unique opportunity to see how a truly elective service can work. And I just think we need to dovetail in on that success, because just speaking to the other trainees, like, that's one of the things that a lot of people have said. Like, one of the general SDRs told me she's done so many lap hernias the last few weeks, which she never would have gotten to do in the public hospital. And similarly, I've done more elective breast operating than I ever have. So, I don't know if NTPF or what it's going to be called, or, but I just think that kind of a model is really what we should look to do.
Okay, thanks. President, you wanted to say something?
Yeah, thank you. And firstly, compliments to all of you who've put a lot of thought, and it's been very well synthesized from what's happened to where we are and where we need to go. And I thank all of you for it. There's a recurring thing, is how are we going to deal with the backlog and the ongoing needs? And we're not going to be able to do it within the public sector as it now exists. So are we going to outsource it to NTPF? And Oscar has set out all of the problems there. I think the HSE is beginning to understand this. And I think they're beginning to come with the thoughts that instead of supercharged NTPF, that they may actually buy out time and beds within private hospitals, so that we will have a modified version of what's gone on before to deal with the surge. And that then gets over Oscar's very sensible concerns about indemnity and trainer and trainee interaction, so that it will be a bit of a Rubik's Cube to work out how we will get the trainee there. But I think, for example, if there is 1 day a week where there is theatre and bed capacity, that the team from the public hospital goes to the private hospital, that strikes me as being the only way we can get through this with the current resources. But I want to thank you all for very, very good input.
Rustam, you wanted to say something as well there, or yeah?
Yes, I just wanted to add to Christian Roden's point. I think the use of elective surgery centres, whether they're Model 2 or Model 3 hospitals within the HSE structure, or whether they come in the guise of additional capacity purchased in private institutions, I think are going to be the key. And I was just looking at some tweets coming through. Fergal Bowers just indicated some recommendations about self-isolation for 2 weeks before elective surgeries and patients having to be COVID screened and all the rest of it. And you cannot have a situation that we have now in Model 4 hospitals where on the eve of your surgery or the morning of your surgery, you're told your surgery is cancelled because the beds aren't available, etc., having been through that self-isolating period and all the rest of it. So I think we really need to have a recognition that a certain level of surgical activity needs to be protected in tandem with providing acute care for all the other medical presentations in the emergency room.
Okay, thanks. David, a very kind of important question that's coming in a lot actually is people, I suppose, are concerned that we may have to extend training. And I know Roscoe mentioned his recommendations that it should be a last resort, and certainly that's it. But it may actually be the fact that just because of COVID and because of you can see the varying impacts there on the data that was shown earlier on, that you showed on the impact on certain specialties. It's going to be really hard to make up that ground, perhaps. And, if that happens, how do you think we should approach it or minimize it?
Well, quantity and quality aren't the same thing. So I think the key point is that the remaining time on a person's program needs to be used to best advantage, and it's up to us to help them with that. Certainly, I wouldn't put that out as the first plan to extend training. I think that's behind glass break in event of emergency. It wouldn't be something I'd be enthusiastic about going down. Again, we can't predict the future. Lots of opinions going around at the moment, how long all this is going to last. If it went on for a long time, we'd have to keep our minds open, but it wouldn't be where I think we'd like to go at the moment. I think the plan is to try and get as much quality in the training opportunities that people have at the moment, and to work on the quantity where possible, optimizing their own hospital opportunities and maybe getting to regional hospitals or private hospitals. A lot of talk about NTPF and private hospitals, but that'll favour or be more easy and accessible for people maybe in the big cities than across the country. So it's not going to be a solution for every trainee. So we will have to think about how we can get everyone through it, but extending the time wouldn't be where I'd be thinking at the moment. And there's plenty of precedents in terms of if you will, there have been strikes, not long ones, but there have been strikes in the past. People have taken leave for various reasons and got through their training. And I think if it's competence-based training, it's not about exclusively the length of time. It is about the quality and what a person can do at the end.
Thanks, David. That's great. Now, I'm conscious of time for everybody, and I appreciate everybody hanging in on today because it's a really popular webinar tonight, massive numbers. But President, I'll give you the last word on this.
I always enjoy having the last word, Kieran, you know that.
And that we all know, yes.
Thank everybody again. And just to say, we've had over 100 participants in this, which is very, very good on a sunny Wednesday evening. Next week, we hope to have Colm Henry, who is the Chief Clinical Officer in the HSE, speaking to us next week. And I mean, we need to make very clear the synthesis of what we got from this evening. We don't need to be too abrasive, and we have to look for solutions. But I think I would be optimistic. I think there is an opportunity for disruptive innovation. There is an opportunity to bring in the separation of scheduled care from acute care and the protection of surgical pathways, which we've been looking for decades. My entire professional life, this has been the mantra that we've been facing. So thank you, everybody, and good evening. And I hope there's still a little sun shining when you get out there.
Thank you, everybody. Good night, and talk to you next week. Bye.